This conference will now be recorded.
Hello, everyone. It's John Antonucci. I'll be moderating tonight's high-risk, advanced, metastatic AnCan prostate cancer discussion group. I'll be backed up by Rick, who's our founder, and I don't see any other moderators here right now. Am I missing any? We're grateful to Bayer, Johnson & Johnson, Myriad Genetics, Helix, Blue Earth, Foundation Medicine, and Novartis for helping support AnCan and its mission to have these educational and support discussion groups. We're all going to be recorded. If anybody has an issue with that, you're free to change your name, blank your screen, send me or Rick a message. But since there's no newcomers here, I don't think we have to worry about that too much. I'm going to start with Rick. He's got a few things to bring us up to speed with.
I do. Thank you, Dr. John. And first of all, I have apologies from Len, who is en route to Venice, Florida for his winter sojourn, except it's going to be very short this year because he's expecting another grandchild, so he's going to have to return to the cold climes. But he said he wouldn't be able to make it tonight, so there you go. So there's a few housekeeping things for simple stuff. We decided to move the fourth Tuesday meeting, which would have been on Christmas Eve, to back a week to the 31st, because a lot of you do celebrate, we know, Christmas Eve with your families and would like to be with your families. And we figured that you aren't a big partying crew. So if we did a meeting at 6 o'clock on New Year's Eve, we'd still finish early enough for most of you to do whatever you'd like to do. So there you go. So that meeting will definitely be a week later, but will take place. Second thing, yes.
I did access the AnCan calendar a few days ago. It'll have to be changed in case anyone else.
Yeah, it needs to be changed. I've got to make a note. I haven't told Alexa. I've got to tell Alexa, so I'll send a note to Alexa afterwards. I forgot to tell her today. Next is that our AnCan fundraising letter was sent out by email this morning and should have been in all of your inbox. If it wasn't in your inbox, then check your spam and whitelist us. But otherwise, it should certainly be there. If anybody didn't get it, they can send a message to one of us, to me, or better still to Alexa, and we'll just forward you. But it'll be coming out again right the way through the month. As you know, we try to push this as best we can throughout the month. It's the only time we do our fundraising. I won't say any more because it's all in the letter, and there are some very nice pictures in the letter as well. So I will give a shout out to David Muslin, who chairs our fundraising. Thank you very much, Mr. Muslin. The next thing is still continuing to push the survey. We're up to 345 as I looked this morning. We really want to try and get to 500. So hopefully everybody in this crew has responded. But if there's anybody listening on the recording and you haven't responded, please respond. The link will be on YouTube and on the blog, and you only need to respond one time. If you've already responded, it doesn't have to be a second time, but we just ask everybody to please try and respond because we need the results. And the fourth thing, for those of you who arrived a little bit late, I am going to share my screen, and let me find what I'm looking for. Share. Most of you know who this is, I think. And can you see the screen? Do you recognize that face on that screen? If you don't, a couple may not, like Bob, because he's kind of new, but it is our moderator who should be here today, but we can't afford him anymore. So I think he's gone off to Milan to walk the catwalks in Milan. That's what we heard earlier on. We also understand that he has a new agent by the name of Gary Peters. And so I'm waiting for that note from Mr. Peters as to make sure we can afford him. But if you don't know him, it's Ben Nathanson. This is his second claim to fame this year, because he did a fantastic interview with PCRI and Alex Schultz earlier on in the year. And this is in Cancer Health Today. If you click on the pinned notice at the top of the chat, you'll see 4 messages there. And the top message is the article, and you can click on that article and you can read Ben's interview later. He gave AnCan a very nice plug. And we're hoping, since this all came about through Howard Walensky, we're hoping Mr. Walensky will push AnCan, because we'd like to have an AnCan article for the 150,000 readers of Cancer Health. It would be very nice. And that's the end of that's all I got to say, and I'll hand back. I think Larry Schuller came in a little bit late, so he may have he was here and then he left. John, he was here in the first 10 minutes.
I saw. Oh, he was. Okay. Well, I'm going to, by the way, regarding that survey, I hope nobody's holding back because they don't have anything good to say. My mom used to say, if you don't have anything good to say, don't say anything at all. We don't feel that way. We really want any feedback, even negative, because we want to make sure AnCan is as best as it could be. I'm also going to break the 10-minute rule, and because I don't have any newcomers, and just check in with the guys that came in late. Michael from Denver, do you want to bring up anything tonight?
No, sir. Thanks for asking.
Okay, Michael. There's a Rich there. I don't know. Is that Rich Jackson? It's
it's Rich Klopstein. No, thank you. I appreciate it.
okay.
Thanks, John.
And now I got Larry. Want to bring up anything, Larry?
I'm still having trouble getting into the session, but that's my problem.
You seem to have solved it now.
I came in and I was going to put my email address in, and then it was gone. So I went out, and I've had a hard time finding my way back in. I'm supposed to be computer literate, but sometimes it's a by guess and by golly proposition. And I'll have my cancer biography ready next week. I promise me.
Okay. Very good. But you're making progress because I can hear and see you very well. Larry Fish, somehow you jumped to the end of my screen, but I already asked you, right?
Yeah, I got bumped off and had to reset and sign in.
Okay. And Brian? Would you like to catch us up to date on anything? Ask any questions?
Don't have any questions. I'm just listening in. I had treatments in 2021, and I'm listening to you guys just who've got more experience than me, what I've got to look out for in the future just in case.
Brian, have you ever had a chance to have us take your history and
Brian has been a long time attendee of low intermediate.
Oh, okay.
Okay, and so he's not. We love having him here, but he sort of listens because thank God he doesn't need to talk to us yet. But when he does need to talk to us, we'll have him bring us all up to date.
All right. Well, I'm glad to hear that you're just visiting and that you haven't been promoted to this group.
No, he hasn't. And if I'm not mistaken, oh, I know what it is. Yes, and your brother, how's your brother doing with his pancreas cancer?
Unfortunately, passed away a few weeks ago.
Oh my gosh, I'm so sorry.
Oh, sorry to hear that.
Oh, I'm
Yeah,
sorry.
we buried him on November the 12th.
Oh gosh. Okay. Thank you for telling us. And we will inform the pancreas group as well. Sorry.
Darn it. All right.
Okay.
I'm going to go to Doug.
We have a caller, by the way.
Wait. Yeah, I just recognized that we have someone on the telephone. Who's that?
Henry, is that you?
Yes, it
Who's
is.
on? Oh, it's Henry. Okay. Would you like any time?
Yeah, maybe in the end, just a minute or two.
Okay. Dr. John's got you.
Okay. Now I'll get back to Doug. Tell us what's on your mind. And oh, he's on the phone, I think. I'll skip to the next guy and get back to him. Frank Dumbra.
What's happening?
Hey,
How you guys doing?
good. What's up with you?
I'm doing all right. I mean, I start my third Pluvicto treatment tomorrow, so I pretty much know, the ride that I'm going to go through for the next couple of weeks. But I mean, I'm good. I'm healthy. My I mean, I'm not one of these guys that's like, going to jump and say, oh, this is great, because I know it's just a part of the journey. That my PSA was like 190 when I first started the Pluvicto. Now it's in two treatments, it went down to 5.6, 5.61. So, that me, or is that somebody else? Anyway,
No.
so other than that, I mean, I started walking. I'm walking like 3 miles a day. I mean, I'm eating good, just I'm living my life. So anyway,
I'm glad that you're walking. Do you suffer from fatigue?
I'll be honest with you. I started some THC and some CBDs, which I hadn't smoked weed since I was a teenager. Man, I feel great, man. I mean, I couldn't even walk like 2 houses up in front of in my street. Now I started walking a little bit at a time. Now I'm up to like 2-3 miles a day. So I mean, yeah, that's what helped me. So I feel
That's
good on that
remarkable.
account. If I don't take that medicine, I mean, I'm like crap. My stomach is like crap. I'm like, fatigued. I'm like down in the dumps. So, I mean, I'm not saying this is what anybody else should do, but this is what I'm doing.
Well, we're not, philosophically against that, and
Yeah,
it's not illegal anymore. And
right.
so if you are getting benefit, which sounds kind of like a remarkable amount of
Oh my
benefit,
God, you have no idea.
it's improved your mood and improved your energy and your exercise tolerance.
Everything.
So what is it? A combination of the two in a pill form? Did you say a pill?
What, with the weed?
Yeah.
Actually, I get the gummies, and I started smoking some THC with the CBD in it. And I actually, my doctors, my my oncologist and all of them guys. I tried talking to them about it, and I'm not a drug seeker. I mean, by any means, but I've heard that some of this could be good, and so I asked my doctors about it, and they were like, "Nah, you're not ready for that." So I was like, "All right." So anyway, one of the ladies who works with my wife is a nurse, and her son has some kind of real serious disease, and he takes it. So she gave us some for me to try it on because my first Pluvicto treatment just knocked me on my ass, and the second one after having the gummies I felt better. Like I wasn't even down. I mean, I just kept moving. And anyway, so
Did
I
you
mean, I'm
find the potency really different from the old days when we used to
You
smoke?
know what? Everybody says that. I think it's bullshit. I mean, I'm just a straight shooter. I'm sorry, but I don't believe that because I smoked a lot of weed when I was a kid, and I think now that the weed is regulated, for me, there's like you can get weed or the THC and the CBDs. They call it whatever the medicine. I call it the weed, but you can get it and it's more regulated. Like it's not making me this paranoid kind of like it's not giving me the the psychosomatic effects. It's giving me more of a good feeling, able to eat, calms my stomach, gives me energy. So there's a difference. That's the difference. Like back in the day, man, we used to smoke a couple of joints and we'd be like, laying on my head, laying on the side of the window, listening to Led Zeppelin or something, or the Who, who knows? But yeah, so I'm just being real. So anyway, this is my experience right now. But I'm a hard fighter. I mean, I'm not a guy that's gonna lay down. I'm living, man. That's what I say. I'm not dying, bro. I'm making plans for living.
You're on the side of life. That's really good. I
Oh my
just
God,
looked
man.
up
Yeah.
Pluvicto and to see if there was any uh, adverse drug reactions with cannabis, and nothing came up. Does anybody
That's
else
good.
know of any trouble he could be getting into with this?
I
What
mean,
else are
not
you on
only
besides Pluvicto? You're still on ADT, right?
I get right now. I'm getting the Lupron shot or whatever it is. Is that the ADT?
Yeah,
yes,
And then I'm getting the bone shot, the Xgeva,
good.
and then I'm doing Pluvicto right now. Those are the main cancer drugs I'm on right now.
You mean the only cancer drugs you're on right now?
Yeah, I think so. Yeah, yeah,
Okay.
definitely.
Okay.
Yeah.
Somebody was about to say something. Was it you, Rick?
yeah. I was just going to say that it's disappointing to me a little bit that the people at the James are discouraging the use of medical marijuana for
Well,
somebody
hold on.
that needs.
This isn't
Go
the
ahead.
James. This wasn't the James.
Oh, okay.
Because we're trying to switch to the James in January because of my
Got it. Okay.
what I'm getting the whatever Medicaid, Medicare,
Okay.
whatever it is.
Medicare. Okay.
Yeah.
So,
So now
yeah.
this was like my regular doctors, like the my regular oncologist, who my wife is like ready to kick him in his rear end, and so we got switched over now back to the urologist because he's the one that handles the Pluvicto, and the radiologist who does that. Real cool dude, get along with him great, plays guitar and stuff. But yeah, so we're going through some changes of once we
Okay.
get off my wife's insurance, then we're going to go to the James. We already also got in touch with that. I can't know the one up north. Is it in Milwaukee or I can't remember the name of that place she talked to. Anyway,
Uh, Gary Peters, you have something to
Um,
react to
Frank,
this?
do you take the gummies before the Pluvicto treatment or after the treatment?
well, this would only be my second treatment that I have the gummies. So the last time I took them after the treatment, and yeah, it doesn't for me. For me, it's the routine. I'm like, I'm like eating like one gummy a day in the morning, then one in the afternoon, and that's about it. But
But you
it's
don't
kind of
have
like,
them. You don't have them every day. You do it at the time of the Pluvicto treatment.
no, I've been doing it every day because without these things, I wake up in the morning and I'm like sick to my stomach and I just don't want to
Right.
do anything. And then I kind of mill around, take a cup of tea, whatever, and then I take a gummy and then I'm ready to go. It's crazy.
I think the
I mean,
reason that somebody might have thought it's too early for that is because they might have been thinking of either the effect of THC on chemotherapy induced nausea and vomiting, or they might have been thinking of the effect on pain for people with advanced bone metastases,
right, and that's me.
but you have some.
Frank, you have no trouble sleeping on the gummies?
I'm not a big sleeper. I mean, I get, sometimes I stay up till 2:30 in the morning, get up at, 9. I mean, 6, I get my 6 hours, but yeah, I don't
I was
notice the difference.
just wondering because it sounds so activating, like you're taking the indica rather than the sativa. And
Well, I just got some of that to try that.
which
The indica. I just got the indica.
that's not what you're taking with all that energy that you get. It reduces your
No, I've
fatigue.
been taking like sativa or a hybrid.
Activa.
Yes, sativa or like a
Sativa.
hybrid is what I've been
Or
doing
hybrid of
because
both.
my body is way different, I think, than the average person. I don't know. Like I could take a downer and I'll be up. That's always been
You
my story.
everything's backwards with you.
but I landed in a good spot. I mean, I'm not trying to promote nothing. I'm just being
No.
honest.
No, we're fine with that.
Yeah. I mean, if anybody
Uh,
has some advice that it's not good, I'm open for it. You know what I mean?
I got Brian here.
Yeah,
Can
Frank.
you chime
Frank, I
in?
may have missed this. With the Pluvicto, did you experience dry mouth or dry eyes?
No, but the one thing about my eyes is they got like I busted some blood vessels right on the inside of my both eyes because I was retching so bad. But that's about it. I don't know if they were dry eyes, but they were both like two big red blood vessels. And that's about it with my eyes. No, no dry mouth. I mean, I constantly drink water all day, and but nah. The only thing I had was fatigue, sickness, I don't know, pain, yeah, and from that damn bone shot too, because I do the bone shot and then the Pluvicto. But anyway, I'm good, man. I'm like, I mean, I'm
Jimmy has his hand up, and Jimmy, after you comment for Frank, you can just keep the floor and bring up what you were going to bring up.
Okay.
Yeah, that's
I was
cool.
going to say, Frank, I can appreciate that you don't think that it's any stronger than it was in the old days, but it is most definitely stronger. It just may not affect you that way.
Okay.
All marijuana is way stronger now than it used to be, but that doesn't affect you. What matters is that you're enjoying it. It's been good for you. Most of us will say here, don't let anybody tell you that you shouldn't be taking cannabis or gummies. We have a life-threatening disease, and it brings us a lot of relief. Some of us, and it would be crazy for any of us not to take it. I think if it's bringing them relief and it makes them feel better.
Thank you.
Welcome. Okay, I'm supposed to talk. Okay, yeah. I'm only bringing this up because I'm a little stuck. I'm not sure which way to go. I don't expect any answers out of our group because it's not directly related to the cancer. It's related to the ongoing consequences of treatment, which are numerous. And as some of you know, I had artificial urinary sphincter inserted because my incontinence was so relentless. And it worked well from the beginning, but I also had intermittent high fevers shortly afterward, every 4 or 5 months, very high fevers. And I had a lot of swelling in my scrotum, a lot of redness that would come and go, and it has continued to, the fevers have mostly dissipated, but I did have a pretty serious one in June, which isn't all that long ago. I did go. I still have redness. I still have swelling. I went to a urologist a couple of weeks ago that my PCP recommended, and he's one of those guys, those doctors that sort of their specialty is, unscrewing up what the other doctors have done. I like finding those if I'm having a hard time with something. I call them Dr. Houses. If you all remember the TV show, hopefully they have a little bit better bedside manner than that guy. And this guy did. He suggested that I go ahead and stay where I am for another couple of months, see if I don't get sick, and then he would like to take it out and replace it, which is something that some people would advise me. Some guy like that crazy Brit that's on here sometimes advised that, but we don't need to talk about him.
I heard of that guy.
I really, yeah, he's there. He is. I knew he'd come back if I said that. He says, "Just remember, you heard it here first. You heard it here first." I was like, "Yes, I know, I heard it here first." But he wants to take it out, and right now the problem I'm having, which I don't know if I want to make any noise about it. It's not terrible. What's happened is that now the swelling that I get is very tight. It's very. It used to just be my testicles got big. Now they get kind of they're more compact, but they're very dense. With I don't know if it's scar tissue or the swelling or whatever it is in there, blood. But it's making it hard for me to find the tab to release the urine through the sphincter. In case you don't know, it's a tab and a balloon and a cuff. And you reach down in your nuts and it drains the urine. And if you can't find it, like I sometimes can't, especially if I've been exercising or if I'm wearing tight pants or something, which I try not to do, it's almost a little bit worrisome because I can't find it right away. And when I do find it, sometimes the stream is weak because I haven't gotten a good handle on it. I've been able to eventually get a hold of it, and it's tough if I'm not at home. It's tough if I'm in a public place. It's tough, period, because the last thing I know that I want is to have urinary retention, and that's just never any good. And when I'm sort of like maybe less than 8 weeks away from going to see this guy and getting this thing replaced, taken out, whatever, I don't want to bring attention to it. I don't want to be dramatic, but I think that maybe I should be concerned that this, and it comes and goes. I mean, just to be honest, the swelling will go down tomorrow or the next day, and then I'll be fine. It will sail on. It won't be as red. But it's definitely always in a state of redness, swelling to some degree, and it's just not right. And I don't want to just be popping antibiotics or getting IV antibiotics in the hospital like I did in June. Every time something like this comes up, we all know that if antibiotics is your best solution to your problem, if long term it's not going to work because you'll develop a resistance to it. So that's my situation. It's not great.
Jimmy?
I don't expect anybody to have any answers, but that's where I'm at right now.
Jimmy, is the swelling and redness all on the one side where the
No,
implant is?
both sides.
Both sides.
And the other thing is my penis, previously, I know it's like a joke, but I have to joke to get through this, I used to have this big, beautiful sex machine. Now it's this little thing, and the skin envelops the head to where I have to dig out and find it. And sometimes when I'm digging out to find it, especially if it's cold or something, it's actually hard to get a hold of if I'm also trying to work the pump at the same time. So it's I know complaints precisely, but well, that's just I know complaints generally, but that's a tough one precisely also.
So my favorite Jimmy quote from early on when he first joined us is that he used to have a Ferrari and now he's got a golf cart.
They take away my Maserati and gave me a golf cart when they gave me a prostatectomy. They said, this will be just fine for you now. You're getting older. You don't need the Maserati anymore. It only gets you into trouble. We're going to give you a golf cart and everything's going to be great. They weren't lying. They gave me the golf cart. And so far, so good with the disease. I'm thankfully, enjoying a remission right now. But it's a little tough down there. Okay.
Jeff?
Jimmy, you never mentioned whether or not you have leakage when you have that device. Is there a little bit of leakage?
A little bit.
Oh, okay. I heard from somebody else. Yeah.
Yeah, now I have a little bit of leakage. It's not perfect, but it was the opinion of the urologist that saw me in the hospital when I was in there for my latest fever. that I have cellulitis and that I have to keep it very, very clean. And that's my best chance of not getting any serious infection, because I had a staph infection when strep B, when I went to the hospital. I was tested. So these things are serious. I could have had sepsis, but I didn't. I don't want to be a tattered suit on a stick, so that's why I'm fine otherwise.
Other Jeff?
Jim, what does this doctor say about doing it a second time? What's the success? What's the risk?
Well, to be honest, one of the I would say minor drawbacks, because it really has done its job. I mean, relentless incontinence is a miserable thing, and it really, really helped me so much. But they have a lifespan of anywhere from 4 to 8 years on average, so they have to be replaced anyway. So that's that. They don't last the rest of your life or anything.
So it's almost like a maintenance item.
Yeah, just one more maintenance item, Jeff. You got any of those?
Yeah.
Jimmy, as you know, I've had some similar experiences. I also have a AUS artificial urinary sphincter. After the surgery, whereas Jimmy had serious urinary retention, I had really blinding pain. There was a unusual amount of pain for several weeks. I felt as if he had left a couple of scalpels inside me. That's what the pain felt like. It finally went away with the help of some anticonvulsants for pain. It took a long time. The surgeon claimed that the pain was because I had had previous radiation therapy, and the radiation oncologist blamed the surgeon. Surgeon blamed the radiation oncologist. So you know how that goes. The idea of another similar surgery, I would just hate that idea because it was so awful. So far, my device has not failed. It's not really a tight closure. I still do have leakage, and if I make an effort, I can actually pee through it. So if I had an experience like losing the pump, like you do sometimes, I probably wouldn't get into that much trouble. So I'm not 100% happy with it. It did improve the amount of incontinence by 75-80% at least. So I'm really just a little dismayed at the idea of you having another one. And usually if there's something in a person like hardware or something that the doctors have put in and there's reactions to it, usually they just want to take it out and not put anything new until things are completely normal again. But
that may be what he wants to do. I'm not sure. He's not sure either.
Okay.
But the only retention I had was right after the surgery. What happened?
I know.
The surgery, the next
day. It was
day,
just the same day, yeah.
And they had to recatheterize me, and they didn't have anybody to do it because the team was all down doing a surgery, and I had to wait a very long time. 800, 900 cc's of urine is uncomfortable, guys.
Yeah, that's probably 3 times as much as I could hold. I saw a hand go up. Larry Schuler.
Yeah, I'm going to be having an artificial urinary sphincter put in at the same time my reservoir for my penile implant is also replaced, and that's going to happen next Tuesday. Any advice?
Yeah. Celebrate that you're getting them both done at the same time, because it's extremely common, as you know, to have that happen. And this could square you away in 2 areas at best.
Knock on wood.
Yeah.
Same surgeon who did my prostatectomy and the implant back in 2017 is going to be doing this surgery. I like him and I trust him.
You had an implant in 2017?
Right.
Oh, so you're just
Penile
getting
implant.
AUS soon. You said an implant and an AUS. You're getting both?
Well, I had the implant in 2017. I had prostatectomy in 2023,
Okay.
which took out the reservoir for the
Oh,
implant.
I see. Yeah, I see. Yeah.
Now we're getting both of those fixed.
Interesting.
Because the prostatectomy left me profoundly incontinent and impotent, which I
Yeah,
thought I had the
likewise.
impotence covered, but nope.
Larry, the urologist tells me that if all goes well, I could get an implant as well. I just have to take it one step at a time. I've wanted an implant for a while. Even though I joke about the golf cart, I'm not really voluntarily a golf cart kind of guy. So we'll see what happens.
Well, if you can't have two pumps in your scrotum, the malleable implant is much easier to install, a little harder to live with, but it works.
I've heard that. I can't conceive of it myself, but I'll keep an open mind.
So
Well,
you
I'll
had
put
no
in
regrets about that penile implant, huh? It was
none
successful.
whatsoever.
I always hear that they're successful, even though it kind of scares me. I did watch a video of the procedure one time, and it wasn't pretty.
No, it's scary to look at.
Yeah,
The procedure is
yeah.
the implant itself. It looks perfectly normal. I'll put in a plug for organization franktalk.org. It's loaded with guys who have erectile function problems and other problems as well. That it's not a spam fest or anything like that. The moderator keeps a tight lid on misbehavior, and is full of information.
Thank you.
That's interesting. The only thing I'm going to add is that, the reason I'm invested in getting implant, or at least exploring it, is because I'm not on ADT. So when I was on ADT, I had absolutely zero libido, and I was supposed to do the penile rehab after the prostatectomy, but I couldn't have cared less. I just put my head in the sand, and it didn't matter to me. And so now, a lot has happened, but it is hard to imagine another surgery. I mean, you can't just keep going after, you're getting old. You can't just keep going after these same areas and just, cutting in there and doing stuff, even if it's supposedly you can. So I'm concerned, but I'm okay. I'm
If it
sorry,
gets
more guys don't have
replaced, if it gets replaced, there'll probably be a few weeks afterwards before they even activate the thing.
Yeah, they don't activate it right away.
No.
Well, anyway, I'm fine.
Larry, you should know that too. When you get an IUS, it's useless for the first few weeks while you heal up for the surgery.
Yeah, my surgeon is hopeful that he was thinking, by the end of January, and I'm hoping that I can have sex and be urine free by Valentine's Day.
Okay.
There's a target for you. Okay, thanks.
While I've got the floor, yeah, I'll change the subject a little bit at the risk of repetition.
Wait just a second, Larry. I'm actually going to get to you anyway, aren't I? Do I have you on my list?
Yeah, I'm on your list, but I'm not ready for the presentation of my history.
Oh, that's right. You're for next week or something like that. Let me get to you. Let me get to you a little bit later, Larry, so I can stick to my list. Doug, could you tell us what you got on your mind?
Maybe you want to come back to me later. I'd like to talk about statins and how they're related to the therapies that we use.
Go ahead.
Okay. I don't know where I saw it, but when I was first starting out, after I was diagnosed, I was told that you'd be better off if you're on a statin, but if you're not on one, don't start now. So I just had my first calcium artery scan.
Coronary calcium score.
Yeah, coronary artery calcium, right. And it's quite high. And
what number?
About 1,300.
Okay.
So I saw some places where that's considered extreme, some places it's considered moderate. I don't know what, you might have some perspective on that. But what kind of experience have other people had with this? Is it a problem I'm having by myself, or is it common?
Larry?
Are you diabetic, or have you had your cholesterols and stuff checked?
Cholesterol's fine, not diabetic.
Oh, okay.
Your cholesterol is normal? Your LDL cholesterol is normal?
Right. I don't have the numbers right now, but I'm not abnormal.
So here's a question. Should a person with a normal LDL cholesterol, and of course we got this new, lipoprotein little a, I don't know if you had that checked out anymore, but what you do is you look at your LDL cholesterol and then a whole bunch of other risk factors such as family history, diabetes, hypertension, things like that, and add up to a level of risk. And once your risk is calculated, you decide whether to be on a statin or not. So you have a very high coronary calcium score, normal LDL cholesterol. How's your other risk factors, such as level of exercise, HDL cholesterol? We know your blood sugar is okay. Blood pressure, are you on blood pressure meds? Things like other risk factors like that. And everybody really, for any of you, everybody should kind of pay attention to this a little bit, because those of us with prostate cancer, we often die from heart disease. We're at considerable risk for heart disease, particularly from our ADT, but anyway. So let's all pay a lot of attention to getting the very best preventative cardiac care we can possibly get, because we are at risk. So what do you got for risk factors, though, besides coronary calcium score and prostate cancer?
The calcium score hasn't been included in this, but prior to that, it was 35% in the next 10 years.
You were what?
35%.
What's that, your risk over the next 5 years?
10. Yes. Over the next 10 years. Right.
10 years. 35%, 10 years. So, I personally would probably go on a statin. I might even toy a little bit with the idea of aspirin, but I don't think so. Let me ask Dr. Jeff to help me out here a little bit. What would you advise in a case where somebody has those two risk factors?
So personally, I had elevated cholesterol, elevated triglycerides, elevated LDL, and I went on first Crestor and then Lipitor, which I was on for 4 years, 5 years total. And I noticed that I had muscle discomforts. When I'd walk, my muscles would hurt. It would sometimes stop me from exercising. We decided to stop the Lipitor completely about 3 weeks ago, and that muscle discomfort has improved quite a bit. So it's a balancing act. My last cholesterol and triglycerides were excellent. The numbers were so normal, and I stopped it, or we decided to stop it. And I'm feeling better off of the statin. So for me, I'm done with statins because I'd rather be able to exercise. I'll follow my cholesterol, follow my triglycerides. If they bounce up, I can go back on them. But for now, the discomfort from it, and there was brain fog also from it, and I think those things are improving, the brain fog and the muscle tenderness. So I think you have to balance. Are you getting side effects? And is it worth having them, or is it worth not having them and being able to exercise?
Is it once you have the calcium deposits, do the statins reduce those deposits, or are you just pretty much it's not going to get worse?
Well, statins do nothing for calcium. You know, statins don't lower your body calcium. Statins lower your lipids.
What happens is that you, over a period of many years, people at risk develop plaques in their coronary arteries, and those plaques have the capacity to get inflamed, rupture, and cause a heart attack. If those plaques stay around for a long period of time, they tend to calcify. The calcium is visible on X-rays, and the plaques are not. Maybe somewhat on CT scans. So it's a marker for the fact that you've had long-standing coronary atherosclerosis. So it will not, like Jeff says, it will not dissolve the calcium. However, it may slow or stop the process of building up more atherosclerotic plaques in the future.
So are there any ways of reducing those plaques that are present?
There are some cardiologists, probably the most famous one is Dean Ornish, who claim that if you exercise every day, meditate every day, eat a vegan diet, you can actually reverse atherosclerosis. I don't know if this is widely accepted or not, that you can actually reverse it, but I think you can significantly affect your chances of having a future heart attack. In fact, there is, now that I think about it, there's a calculator where you put in your risk factors and then you say, what will happen to my 35% 10-year risk if I add a statin? And you put in your age and everything like that. Maybe I can dig it up for you and write to you if you put your email address in there. Unless Jeff has it right off the top of his head. No. Okay. Write to me and I'll look up the calculator and see what the effect of this is. Give me either your phone number or your email address in the chat. Okay.
Okay, thank you.
Okay.
One more question. Are there any statins that are known to have less side effects than the others as far as the muscle?
It's individualized. It's really up to the individual. There are some people who might have muscle aches with rosuvastatin, like Jeff said. It's quite a potent statin and might not on moderate doses of atorvastatin. It's worth trying a second statin, which he already, I think he said, did. Probably after you've gone through two. I don't know if I'd keep on going through more and more.
Thank you.
I got some hands up. David?
Yes. On the third time that I was on ADT, my lipid panel readings had all gone out of range, and I didn't want to take a statin, so I wound up taking fenofibrate, which is an older drug, and that brought my readings back down into the normal range. And I didn't notice any side effects from that.
Jeff,
I didn't understand that well to find it. Oh, could you spell that or pronounce it really carefully?
FENO FRI
FIBR
Yeah, I think, yeah.
I would do the statin first, but that's a great idea. If statins in the future, first of all, if they help you, it's going to be hard to figure out if they're helping you in a way because your LDL cholesterol, which is the most common biomarker, is already normal. It's not like you can take your coronary calcium score once a year and find out if statins are doing you any good.
Right.
It's going to be a little harder to figure you out that way. But that's a suggestion. There are old-fashioned cholesterol-lowering drugs. Yes.
Thank you.
Yes, Steve here. Hey, I was having some statin pain in my muscles and ended up switching to pravastatin and having much better results, resolution of a lot of the muscle issues.
Yeah, thank you. Yeah, it's worth trying too before you give up on the whole category of drugs. And my 2 cents. And Jeff, please jump in if you disagree with anything I say. I've got Alfredo with a hand up.
I was just going to comment about statins. And Doug, I didn't hear whether you said this at the beginning or not. Are you under the care of a cardiologist?
No, I was going to request it.
Okay, well, that would be my advice.
Yep.
The questions we've been discussing for the last 10 minutes really needs to take place between you and a good cardiologist. And I think what you'll find is a cardiologist will tell you what the risks of statins are. They'll tell you you'll never need another calcium score because it's not going to go down. The degree to which your plumbing is clogged is a snapshot. You don't want further clogging to occur, and that's where a statin would come in. And I would just also mention there's 2 newer drugs. Because they're newer, they're more expensive. But there are people, my wife is one, who does not tolerate any statin. I think she's tried 6 or 8 different statins in her life. And they all have immediately caused the side effects that nobody wants. So now she takes a once every 2 weeks injection. One of the drugs is called Repatha. The other one is called Praluent. A cardiologist would be prescribing this, not a urologist or a surgeon or anybody else. And that works great for her. Repatha had side effects. Praluent does not. It brings her cholesterol right down to the normal level. So I would simply say your best strategy for pursuing this is you and a good cardiologist. And they will be very good about saying, well, let's switch you from statin A to statin B. Oh, that didn't work so well. Let's try C or D. And that's, I think, the way to go. That's the way for you to go.
What was the one you mentioned after Repatha?
Oh, one drug is called Repatha, Repatha. And the other one is called Praluent, Praluent. And those are the 2 in this new category. They're actually monoclonal antibodies. And the cost of them could be significant or not, depending upon how what kind of coverage you have. But they maybe in the years ahead will replace statins. Statins are very inexpensive now. And statins work well for most people. The side effects we've all alluded to do occur. But again, you want to have a cardiologist. You get on the phone and say, listen, I've been taking it for 3 days. I already have achy muscles. And they're going to say, well, stop that one immediately. So I think that's the route you want to take. And I'll shut up.
Thank you, Alfredo. I didn't realize you were here.
I was late.
That's great. And thank you for the recommendation. I just somehow assumed a cardiologist had ordered the coronary calcium scan, and that's not the case. Anybody with prostate cancer who has any heart disease should have either a cardiologist or a cardio-oncologist. Let me see. I got another hand up. Rick.
Yeah, I mean, quite possibly been on statins longer than anybody else on this screen. I started taking statins in, oh my gosh, well, when I was in my mid-30s, because I had a very bad family history, and my uncle had valves, heart valves, and open heart surgery, and valves replaced in 1969. My father had a whole bunch of heart attacks, and I had a very good doctor when I was originally living in Tucson in around 84, 85, and he suggested I go on statins. I think it was right after my dad got here, so maybe it was 85 or 86. And I've been on statins ever since. And I have a very strange situation where I make an enormous amount of good cholesterol. So I have a very, very low ratio, sometimes under 2. But I still have high overall cholesterol, and I have fairly high LDL. But my HDL is usually anywhere between 90 and 110. So
Oh,
it's
I'm
really
jealous of that.
it's really, really high.
Can't get mine out of the 50s.
No, I mean
It's probably because you row.
Well, I'm sure the exercise has something to do with it too. But of course, when you have such a high level of HDL, it pushes up the total anyway. So that and knock on wood, my heart health is very good. I also my side effects have really always been pretty minimal. The worst thing was not being able to eat grapefruit, since we have an enormous grapefruit tree in the backyard, but I took care of that when rosuvastatin went generic. So I now switched from simvastatin to rosuvastatin, and I enjoy my grapefruit very well. I do get a lot of cramping, but I got a lot of cramping even before I went on statins. As a teenager and in my 20s, so I don't know that has anything to do with it. I did also want to mention that, and I take a very low dose. I think I take 5 mil. I get it confused between that and the lisinopril, but it's a very low dose. I also take another drug, which is an anti-cholesterol drug, but I don't take it for having anything to do with cholesterol. So it may be another drug to consider for Doug, called Cholestipol. I'll put it in the chat window. And it is, I have no idea how effective it is. One of the internists on the call can maybe tell you. But I can tell you that it is prescribed. It's usually prescribed for cholesterol. It works through the liver. It processes through the liver, and so that's what I wanted to. Those are my 2 cents to add on statins. Maybe only 1 cent.
Thank you. And Alfredo says again, those need to be discussed with your cardiologist. What was your specialty, Alfredo?
Internal medicine.
Internal medicine, good.
The only other remark I was going to make is I think you'll find, if you're in a town that has lots of cardiologists, that there are cardiologists who sort of subspecialize. I mean, not formally, but practically. So there are cardiologists who all they do is go to the cath lab and stick hardware in your plumbing, and there's other cardiologists who all they do is prescribe these drugs, and they're intimately familiar with the whole gamut of these drugs, and they don't go to the cath lab and do roto-rooter work. So again, that's why you want to find the person whose expertise is things like familial hypercholesterolemia, which is hard to pronounce, but that's what my wife has also, and that's what Rick was referring to. And you'll find a cardiologist whose expertise, whose what's the word I'm looking for, whose wheelhouse is exactly the topic we've been discussing.
But Alfredo, would you start somebody on a statin who has a very high coronary calcium score and a perfectly normal lipoprotein electrophoresis?
If it was me, I would look at the age of the person and what risk factors they have for dying of something else. The other thing is, though, the counterbalancing argument goes like this. For most people, don't ask me for a percentage, for most people, statins are pretty low risk. And if you're not the right person for statins, you're going to have aches and pains pretty soon. You know, not suddenly after 5 years, but in my wife's case, she has aches and pains the first week and stops immediately. So I think, again, I'm not a cardiologist, so I don't want to speak for them, but I think a cardiologist would say, let's try my favorite statin, let's say Lipitor, and let's see how it goes. And you check with them a week later, and they say, okay, well, let's up the dose a little bit. Or they might change 2 or 3 times to other statins. I think it's a pretty low risk. And since it's something that Doug is concerned about, I would want to address his concern. I don't like to say to patients, no, I'm going to withhold this or that treatment course and let you die of something else. But it is something I think about. Sorry, Doug. Hope that's not offensive.
Thank you. Is Richard still here? Not Richard Fisk, but the Richard that wanted to bring up something. And Richard Fisk, you didn't want to bring up something, did you?
Yes, I did. I asked for.
Oh, you did. So it was you. I didn't put your initial, so I didn't put it. Okay, why don't you take the floor now, Richard?
Okay. Finished 2 years of ADT, Lupron, and abiraterone on October 27th, and then did a 30-day prednisone taper, a slow taper, off 7.5 milligrams. And I have found, it's kind of started during the taper, that my blood pressure in the morning is low. It's not atypical to have it less than 100 over 60 or less. And it takes a while for it to come up during the day. And also have massive fatigue, which may be due to the low blood pressure. From what I'm reading, I fix this with exercise and time. Is there anything else I should be looking at?
Are you on blood pressure pills?
Yes. Yeah, I've been on essential hypertension treatment for probably 2 decades, and that's what my family typically dies of.
Jeff, can you comment, please?
Yeah. So, Richard, check your potassium levels. Being on a diuretic and not being on steroids, and if your steroid removal has not been replaced with your own adrenals synthesizing cortisone, you might have a low potassium, and B, you might have a low cortisone. I will tell you, 2 years of prednisone and 30-day tapering, that's pretty fast. I mean, that's very fast to taper off. The purpose of tapering is to let your adrenals and your ACTH get back in balance. So, you know, I would be concerned that your adrenals are not all the way working and your own cortisol is low. Maybe your aldosterone is high and you have low potassium. All of this is easy to check. It's not.
I have a cortisol. I badgered my hematology oncologist into getting me a cortisol check, which runs out at the end of the month. So I'm looking at right around Christmas to get that checked.
What time of the day are you going to, is it blood or urine that you're doing?
No idea. I just know that it's the check, but I will do it whatever time of day is appropriate.
Morning, right?
Morning?
Isn't that what our tests are standardized against?
I will get
in
the morning.
I mean, there's a couple of things I would say. I'm going to take my own hand down. I'm not a doc. But I can tell you from what we've seen here, 30 days is way too low, and the symptoms you're having are what we see when people taper too quickly. Exactly what Dr. Jeff said to you. And of course, we've got Dr. Jeff, we've got Dr. Alfredo, we've got Dr. John, Dr. Jack, we've got a bunch of MDs in this room today. So, and I think we talked about this with you, Richard, because I think you told us this was what your plan was, and we said, no, you need longer.
Well, I told you what the plan, told you the plan I was given by the doc, and
yeah,
everyone's hair was on fire, so I essentially doubled that on my own.
But you needed to more than double it, and we told you at the time. So, my look, we can lead a horse to water, but we can't make it drink. We can tell you what we've seen with other guys and how much time they need. If you've got an idiot of a hematologist who thinks he can take you off prednisone in 15 days when you've been on it for 2 years, that is an idiot. And we've seen what happens to men. Have you lost weight, by the way?
No.
Okay. But we've seen it. And what I'm seeing in you from the little that I know is exactly what happens when you come off prednisone too quickly. Now, somebody like Jeff or Alfredo has probably seen this 20, 30, 40 times more often than we've seen it.
Is there a way that I've got plenty of meds? Is there a way
Yeah,
I can
you can,
recover
but
the
I mean,
taper?
I'm not gonna prescribe it, but we've seen guys go back on the prednisone on low dose. I think Gary Peters didn't you have to go back on the prednisone? Are you with us, Gary? He was. He must have dropped off. But we'll watch out for him, and he'll come back on. I'm pretty certain Gary Peters went back on the prednisone because
He did.
came. He did, didn't he? Right. So
He did. He did because he wasn't producing it at all, and cortisol.
that's right. That's right.
It stopped.
So, I mean, don't put yourself through this. Don't wait another 3 weeks until the end of the month. Go get back into a good internist or an oncologist who knows what they're doing, and talk to them right away about maybe I need to get back on to my prednisone at a lower dose. I don't know what 2.5 grams, 5 grams. Get back on, feel better, and come off more slowly. Guys can take 6-8 weeks to come off when they've been on, right? I mean, let me turn this back to Dr. Jeff and Dr. Alfredo. These guys are qualified to talk. I'm not. I can only tell you from anecdotal experience. And I would have bet dollars to donuts, Captain, that you would have had this issue if you were coming off in 30 days. Well, I would have banked it on 15 days and even on 30 days. But and this is for everybody. Why am I excited about this? Because so many of you guys are on abiraterone, and we keep saying to you, come off slowly, come off slowly. We're like a broken record, and we tell you to come off slowly because we see what happens when you don't. Let me throw it back to either Alfredo or to Jeff.
So, Richard, you were on 7.5 milligrams of prednisone for 2 years?
Yes.
Right. So
I started off at 5, and after 3 or 4 months went to 7.5.
Okay, but the bulk of your at least 20 months you were on 7.5.
Correct.
Okay, so I'm on 7.5. And when I finish in August, I already had this discussion, and I had the discussion with an endocrinologist too. So your best bet, instead of an internist, go to an endocrinologist straight away and ask the endocrinologist, how much experience do you have in tapering prednisone that I've been on for 2 years with prostate cancer? You're going to find someone who understands it. But the conversation I had is 7.5 is what you finish your abiraterone on, and then 5 milligrams anywhere from 4 to 6 weeks, 2.5 milligrams, 4 to 6 weeks, 1 milligram, 4 to 6 weeks, and then you could probably stop. But you're talking about over 4 months of tapering down. 1 month, I have to tell you, a doctor who'd say to you 15 days, they're nuts. Yes, if you had poison ivy and you were on high dose steroid, no problem, but not 2 years of steroid. Our adrenals just can't bounce back that fast.
Jeff
All
took
right.
all the words right out of my mouth. I completely agree. And I hate to sound like an advertisement for every specialty, but specialties exist for a reason. And I would absolutely talk to an endocrinologist about this and say, okay, I'm going to check in with you over the next 6 months and have you manage my taper.
Okay, sounds good. Thank you.
One
It's a
other
pleasure.
question, Richard. Do you have any swelling of your legs at all?
Slight.
Your feet?
Yes, slight.
Yeah. So, and have you had that for a very long time?
The legs for quite a while, the feet just recently.
Yeah. So I could tell you physiologically what's happening. You don't have enough, you have too much aldosterone. You're kicking out potassium, you're retaining sodium, and your feet are swelling. So go back on, if it was me, I'd go back on prednisone, probably 5. I might even start again at 7.5, but probably 5 milligrams. But
Yeah,
that's all.
I would agree with Jeff, but I would also make that endocrinology appointment like tomorrow.
100%.
Oh, absolutely.
Okay.
Yeah, we're sorry to come down on you so hard, Richard, but we just don't want to see you suffer, man. And I would bet that if you get back on that prednisone within a week, you're going to feel much, much, much better. Way, way better. Unbelievable. And then start all over again. You get treated at the military hospital, right?
Right.
So
At
can you?
Fort Belvoir.
Right, Belvoir. And can you get an appointment with an endocrinologist pretty quickly there?
Probably not. But I have an appointment with Dr. Paller on January 9th.
Yeah, don't wait, man. You cannot wait.
No, you can't wait for this.
You can't wait. You got to do this week. Do you have an internist? Do you have a PCP you can get to quickly?
But if you go back on the prednisone, you're going to stop all this bad stuff. And if you had to wait on the prednisone, you would be all right. Don't wait if you're not going back on the prednisone. That 100%. But if you go back on the prednisone, you're going to feel much better. And if you have to wait, it's not so terrible if you have to wait because you're on the prednisone.
Understood. Okay.
I just looked it up. They have endocrinology at Belvoir. I put the phone number in the chat.
Yeah, but
okay.
I mean they do, but it's not so easy to get the appointment. So you have to. Is your PCP at Fort Belvoir?
My PCP is at Walter Reed, but they can put a referral in.
Right.
And,
well,
yeah.
Get hold of your PCP and tell them you got to see an endocrinologist immediately, and ask your PCP, is it okay for you to go back on prednisone tomorrow? Don't do it on the advice of this group, because the doctors can't do. They just can't. They can only tell you what they would do, and I can't tell you. But if it were any of us, we'd be going back on. But we encourage you, please call your PCP in the morning. Ask them if you can go back on the prednisone, that you're feeling rubbish. You're pretty sure that's what it is, and take it from there and get some testing done. Don't wait till the end of the month. Get some testing done right away. You need testing done tomorrow. This can be serious. I mean, we've seen some people have some pretty serious side effects from. I mean, I I want to stress that, Richard.
Understood. Okay, thank you.
Jeff Wood, let's have you have the last word on this topic, and then we'll go on.
It's kind of more of a question, with other drugs available, is abiraterone so valuable that we put ourselves at this kind of risk?
Yes, it's a good drug.
Okay.
It's a good drug. When things go awry, like they did with me, my legs swelled up like balloons and my blood pressure was uncontrollable, I got rid of it. But it's the first, I think it's the first drug to reach for when you want to do double therapy.
Yeah, I mean, I just want to expand on that very slightly because there's plenty of evidence, and Len's not on the call tonight, but we seem to think that it's the first drug of choice in terms of an ARSI. And you're better off to start with abiraterone and then go on to something else. Now, it doesn't work for everybody. There are reasons why some people can't take it. There are reasons why some people can't use the steroids. And then they would go to an androgen blocker. But if you have the option and you can deal with it, start with the abiraterone.
So help me out, guys. I have Tom for the next person, but Thomas, I think, if I remember right, did not, and I can't find another Tom.
So Tom Hoffman wanted time. Thomas did not want time.
Tom Hoffman left.
And Tom Hoffman, I can't find. Oh, he's not
He
here,
left.
Jeff?
He left.
Okay. All right.
He told me he couldn't wait this long.
Oh, I wish, you know what, if anybody is at the end of the list and they have to leave early, I'll try to remember to ask you guys if anyone has to leave early, but if I forget, tell me, we'll get to you first, okay?
I told him to come in early next meeting.
Oh, thank you very much. That leaves me with James Thompson as the next person. After Rick has something.
Tom Hoffman's been in a bunch of times and he knows how we run. I usually try and say, if anybody has to leave early, please let us know so we can get you in. That's what we try to do. But sometimes there's a lot of guys and sometimes we forget. But if you've got to run early, tell us. If not, guys, you know how these meetings run. We have a lot of people and we try to give everybody a fair hearing, and so if you're in touch with him, with Tom Hoffman, Jeff Marchi, please apologize to him, tell him, these are 2-hour meetings, and if he needs to leave before the end of 2 hours, he's got to tell us.
Yeah, I'll let him know. But I told him to come in early. That way he can get up closer in the list.
Well, yeah. But sometimes we don't take people always in the order that they arrive. So,
Yeah, we can mess up the order when
he's left a couple of times now because he couldn't wait.
You get what you pay for.
That's the guy you brought in, right, Jeff?
Back on there?
Yeah, he's my Immerman Angels mentee.
Right. Okay. Okay, let's go to James Thompson.
Yes. I'm new to all of this and I'm listening. I'm learning a lot from it. I did have some blood work, and I got to go and talk to my primary doctor to get all the results and everything, and to try to get a referral to an oncologist within Kaiser. Hopefully the same one Jim Marshall got, if I can. But that's where I'm at right now, and I just didn't know that all this abiraterone was going to cause me to have constipation the way that it did. I mean, it was rough. didn't nobody explain it to me, so I didn't know. But I'm getting through it now, and the sweats is the sweats is really, the hot flashes is really coming quite often. But I'm dealing with that, and that's about all I have right now. Is that I'm just waiting to talk to my primary to get a referral.
Okay. James, did you, when we first met you, you didn't know your Gleason score, and that tends to influence what we think. did you have a chance to look it up by any chance?
No, I did not, and
Okay,
I don't have a PSA score either. Hopefully,
right.
go talk to my primary. I'll get that.
Well, I have a PSA of 0.37 for you. Where did that come from? Is that wrong?
Yeah, I don't think I gave you one. I don't think.
Okay,
Right. Yeah.
okay, something
Yeah.
else. Okay, yeah, so we need a PSA and a Gleason score. Now you're in your relatively early in your course of ADT, and you're having lots of hot flashes
Yes.
and constipation.
Yes. Yeah. Last week, constipation was pretty rough, but it seems to be calming down a little bit right now. I'm taking Miralax to try to help it out, whatnot.
Is the Marilix helping?
I think it did, yeah, because today it was pretty easy today.
All right.
Yeah.
Well, you could keep it going and gradually taper it off.
Okay, and also, do you have? I mean, uh, is there anything else better than the Miralax or what?
I think that's, when a person has constipation, you have to first look at the diet. Very, very few Americans get enough fiber in their diet. So look up fiber-rich foods, and you'll see whole grains and things like that.
Mm-hmm.
And make sure there's fiber-rich foods in your diet every day from now forever. And
Okay.
also, you have to drink a lot of water every day because the more water you drink, the more is left in your colon and the softer your stool will be. And exercise also helps constipation. And
Right.
then after that, if the person still has constipation, you have to start turning to medications.
Yeah.
And I know that there are people that take Miralax for a long period of time. I've even seen children be on Miralax for a long period of time, which kind of freaked me out a little bit. So, my particular view is control the symptoms and then gradually see if you can do without it. But let me defer to the internists and see what they think of things like stool softeners or push type laxatives. Yeah, either you guys want to chime in on bowel regimen at this point?
I'm a big fan of ground flax seeds.
Brown flat seeds.
Yep, you get just don't buy them ground because they tend to go rancid. Buy them as the seed, the brown seed. Get a little coffee bean grinder, grind it up, and put it in your oatmeal or your cereal. 2 teaspoons, even as much as a tablespoon a day, and just take it every day. That often solves the issue of constipation.
Okay.
Don't start the first day on a whole tablespoon.
No, start with 1 teaspoon, then 2 teaspoons. You could even go to a tablespoon.
Okay. And another question, caffeine, is that bad for me?
No.
Yeah, so if I want to drink coffee in the morning, that's okay?
Yep.
Okay. All right, well, I think that's all I have for right now.
There's still hot flushes for us to discuss a little bit.
Okay.
A lot of men in this group have had hot flashes. Sometimes they can be really miserable. Sometimes they're mild. In my case, I hardly had any. It was really remarkable. I was going to group and hearing all these guys waking up 5 times in the middle of the night with sweat, soaked sheets and things like that. But well, I see a lot of hands going up, so we're going to hear some experience about hot flashes. Rick, do you want to start?
Well, I want to talk a little bit more about the navigating the doctors, and also first question I have is constipation isn't usually something that we hear that's associated with abiraterone or the steroids.
No.
Does anybody do any of the docs or anyone else have a comment? Because My concern is, James, that if you have constipation, it may have absolutely nothing to do with these meds that you're on.
Really?
What a good
Because you,
point. It could be, what a good point that is. There could be a completely different cause.
It has to
I
be
didn't get
something wrong with it.
constipation from abiraterone.
So you did?
Actually,
I did not.
Right. Wow.
I'm sorry, Jeff.
actually, when I started radiation, if I could step in, Jeff, you want to go
Yeah,
ahead?
go ahead.
Oh, go ahead. Go ahead.
When I
Go
started
ahead, Dan.
radiation, James, at KP, they
Mm-hmm.
transferred it over to Virginia Hospital Center. They got me a really good nurse who got me on constipation issues. Since I'm off radiation, it's not an issue, but I fully agree with the flaxseed. I've been taking it for over 5 years and it's just great. But I wanted to point out that when you mentioned KP, Kaiser Permanente, and I guess you're in this area, I'm with Kaiser also, and my oncologist is Dr. Ferreira. I would highly recommend if you can get in touch with her.
Dr. Ferreira?
Ferreira.
Okay. All right. Okay. What's that lady's name that I was talking about?
So is there any other possible cause for your constipation that you can think of besides the abiraterone?
Not that I know of, because I didn't. I've never had a problem with constipation until I started taking the meds. So that's why I thought it was coming from the abiraterone or the prednisone or whatever. But it was tough. But it's coming around now.
I'm just going to take a look at the adverse effects. Does somebody else want to say something while I'm looking at this?
Works.
I'd like to say something.
okay,
Yes,
well,
yes.
hold on a minute, Jack. Hold on a minute, Jack. And please use the hand up. Use the hand up, Jack.
20%
No, there's
constipation.
on your screen, we're all using the same thing. On your screen, you can put your hand up. Just check for it. That's where you see it in the top corner, and it will really help us. Go ahead, Dr. Jeff, please.
Are you on any Lupron or any Firmagon, anything like that? Orgovix?
Sure.
James? Can you come back to us, James? You're muted.
Yeah, I'm only on high blood pressure medicine, abiraterone, prednisone, and calcium. And I do take a cholesterol pill.
No, you're on Eligard also.
Yeah, Eligard, yeah. Mm-hmm.
Yeah, so that people on ADT can get constipation. I don't think it's that unusual to have constipation on ADT, but I think if you go with the flaxseed or chia seeds and flax seeds, alternate days, I think you'll be fine.
Okay.
Jeff Markey.
Yeah, I found Senna works well. I take Senna and Colace every day, and I had to do it for a few years now, and that seems to have resolved the issue. Senna is just a natural thing, and you can take up to 4 tablets twice a day. And it
Senna pushes and Colace softens.
yeah, so I mean, flaxseed may be the answer too, but those other two have worked very well through my abiraterone days.
How do you spell that medication?
Senna, Senna, Senna.
Okay, thank you.
And Colace is Colace, I think.
Guys, please can you when you're doing this, put it in the chat window, because it's also helpful if there are recordings, and then people can find it in the recording. So I've just put Dr. Pereira in there for for you from before, and somebody else should put these medicines in.
Thank you, Rick.
You want to talk about hot
Dr. Jack.
flashes?
All right. Well, last week I was talking about the motility being slowed down with low testosterone, no testosterone. I'm absolutely convinced. I've never been constipated in my life until I went on this ADT doublet therapy. I mean, I use tons of psyllium husks and lots of water to remediate that. But I'm convinced it's the low testosterone, whatever you're utilizing, whether it's abiraterone, whether it's one of the glutamides, but whatever's going on, you're lucky if you haven't been constipated with this doublet approach. And I do recommend if you're going to take the psyllium husks, which I've done for years, off and on, tons of water, because if you do that by itself, you can really jam things up.
Jack, put the psyllium or Metamucil in the chat as well, okay?
No, Jeff's been talking about psyllium husks all night.
Yeah, I know. Which Jeff?
Dr. Jeff.
Okay, Alfredo just put it in. We're good.
He was talking about flaxseed, I thought, but that's okay. Both are fine. Both are fine.
Let me come back, and then we'll go to Dr. Jeff.
What's that? Oh, shit.
I couldn't see during the day because it's light.
Okay. Let's mute Jeff Marchi. Okay. So let me come back to this issue around Dr. Ferreira. Dr. Ferreira is learning prostate cancer, I feel, through our education, through people like Jim Marshall and people like Dan, and because we keep sending her people, and she's coming up and she's hearing new things, and it's helping her. But she is not a GU medical oncologist. And that is a problem, James, that Kaiser doesn't have a GU medical oncologist. James, I think we've talked about this before, but are you a vet?
Yes, I am. Yeah.
Okay. So what we need to do for you, ideally, and I know that Jim Marshall, Captain Jim, knows exactly where I'm going. We need to get you a community referral from your VA to Dr. Palla, who some of the other folks are seeing, like Captain Richard Fisk here, and other people are in this group, because she understands what you are going through.
Okay.
We can say this 1,000 times in this session, and we probably have, but it makes no damn difference to Kaiser, especially in Virginia. They don't have the expertise, and they don't care. It doesn't matter to them.
Okay.
They deal with this with urologists. They deal with this with oncologists who are ill-equipped. We're the ones who are doing our best to try and inform these oncologists what they should be doing. And it's so frustrating. Now, if you are a vet, fortunately, you're able to go outside the system, but you have to be set up in the VA system correctly, as Doug Dufresne will tell you. You can't just walk in and say tomorrow, could you send me out to Dr. Palla? No, you've got to have a PCP, and then you've got to have a urologist. And then the urologist has got to say, yeah, this person needs to see a GU medical oncologist, and we don't have one, so we'll send you out. But James, start working with Captain Jim as soon as you can, and we will get you over to somebody who can really help you with these issues.
Okay. Okay. Right.
We've got some cool ideas about hot flashes too. Tell us quickly, if you can, how severe they are.
I have hot flashes, something like at least 4 or 5 times a day, and some of them can be pretty rough. I just get to sweating at the top of my head. Like the top of my head starts sweating, and my upper body starts sweating, and then it only lasts for like a minute, and then I cool right off.
Oh,
Well, it's good that it cool off right off after a minute. I bet you want to crawl in the refrigerator when it happens.
Yeah.
We have, let's see, I'm thinking about the time and the number of people, and I want to tell you some ideas about hot flashes. I'll tell you about one really interesting idea. A company came up with a wristwatch type device called the Embr Wave. And when they have a hot flash coming on, they push a button. You see Jeff Markey up there waving his, and it
I have
can
one.
you got one.
I've
Now
been
it can terminate a hot flash, but if it only lasts a minute, it might not be the solution for you. Jeff, how long does it take to terminate a hot flash?
The trick is you have to do it immediately when you feel it coming on. If you don't do it immediately, then you can't stop it quick enough. So a minute wouldn't be enough. It would build
James,
a little bit.
does yours work or not?
I think it worked. Mine's work. I can
At
feel it.
night, they're great.
Maybe that's why it only lasts a minute. Are you using it every time?
Yeah, I use it. Yeah. Yeah, Cliff turned me on to it, so I immediately went and got one, and it works for me.
okay.
Okay. So, watching the time here, I want to get to Henry before we run out. Henry, what's going on?
How's it going, everybody?
Hi, Henry.
I think I spoke to you before. I had caught the COVID some time ago, back in October, September, and my PSA took a little bounce. I guess from my research, it said that it would take a bounce, and it take it between 3 to 6 months to go back down again. My present prior PSA was 0.07. I think it went up to 0.1 or less than 0.1. I guess my question was, I am also a vet, been seen by a urologist at the VA system in Charlotte. At what point should I or could I request maybe PSMA, CT, or bone scan, anything like that? Thinking I'm going to receive some resistance because I think they're following the protocol of the NCCN of consecutive 0.2.
Your last PSMA scan was in April?
I haven't had a PSMA.
Oh, you never
scan.
had one? Oh.
Never had one.
And your PSA is what now? Points up what?
Less than 0.1.
Oh, okay. He's good.
Yeah.
You may not get. Let's see. Remind me a little bit how long you've been on treatment.
Well, I had surgery done in February of 2023 at Johns Hopkins. I just was taking active surveillance every 6 months. Started with 3 months, every 6 months of PSA reading, and my PSA became slightly detectable.
Well, I'll tell you what my doctor is doing under somewhat similar circumstances. He's waiting for my PSA to hit 0.2, and then he's going to put me in the PSMA scanner.
Right. Sounds about like, yeah. Sounds about what I'm being told.
Any
are
dissenting
you having
opinions from anyone?
No, I mean,
what
I would say is this. What I would say is this, Henry. I don't think you need to be concerned about your PSA going from 0.07 to 0.11 or 12. It's just not significant. It's within the margin of error. Plus, you had COVID. So there's no reason for you to be doing a PSMA scan based on that. Now, if you went from 0.07 to 0.35, we would probably be saying, yeah, get your ass over to the VA and tell them that you need a PSMA scan. But I think at this point in time, don't let it worry you. I mean, I hear that it's giving rise to anxiety, but we've got to try and help you with that anxiety because it isn't sufficient a jump to warrant you being concerned. If you in next month, how often are you getting that PSA tested?
At the VA, it's every 6 months. I talk to
Okay.
my outside urologist every 3 months.
Well, first of all, the VA should do it every 3 months, and you can ask for it every 3 months. And if you're not getting it every 3 months, you come back and tell us because we'll take it up with the higher ups and let them know. Because we've got people
Okay, well,
who are high up the chain, but they should not. In a post follow up like you're in right now, where you're still only about 18 months out, they shouldn't be making you wait 6 months. It's too long.
well, they are, and I've been kind of going back and forth with them about this. That's why I acquired an outside urologist, having him do it every 3 months rather than having to wait every 6 months.
Well, if it
Okay.
was me, Henry, I would also feel more comfortable with every 3 months.
Yes.
Yeah.
I mean, it shows you that they think you're in a pretty safe spot, but nevertheless, we're more comfortable with
I'm
3
having
months than
some.
we.
I'm actually having some bone pain in my hips, my legs.
It's highly,
I've been-
highly, highly unlikely that it is related to the prostate cancer, Henry.
Great.
Really, really unlikely at this level. Not
Okay.
impossible, but very, very unlikely.
Okay.
I mean,
Okay.
it's not out of the question. What I will do is I will write to Mike Crosby and I will copy you, and let's see if we can't get this sorted out, because
Okay.
it's just not right. You should at least be able to get to get PSA tests more than twice a year with your follow up, and let's follow that up. In terms of where you're at, I'm sure you have hip pain, but I'd be looking for something other than the prostate cancer if your PSA is somewhere between 0.07 and 0.1.
Okay.
Hey, Henry, you good?
I'm good. I'm good. Thanks.
Okay, let us know. Larry, you got 2 hands up.
Yeah. As far as getting a PSA test without actually having to go to an oncologist and pay the doctor's fee, look for health fairs in your area. You can often get a PSA test for like $25, or you may be able to just go straight to a lab and ask for it. And
Yep, good
also
point.
Okay.
on the PSMA test, if you have an actual concern that there is some prostate cancer growing that could be found by a PSMA test, which is unlikely at your low level of PSAs, then yeah, I would start looking at having a scan of some kind, looking for the cancer. And PSMA PET is the most is the best one you got. But at your PSAs, it's unlikely that you have prostate cancer that to be concerned about metastasizing elsewhere in your body. Now, I am a layman, so take that with a grain of salt.
Okay.
Thank you. Who else has a question about anything? No, good. We got through everybody. It was a nice group, lots of interesting medical discussions. Appreciate the medical backup from the docs. And Larry, do you still have your hand up?
Yes. we were talking
Go
about
ahead.
side effects of treatment early on, and before the meeting ended, I wanted to just toss this in. When I was using Orgovix, I had side effects: muscle weakness, loss of libido, extreme fatigue, mood disruption, cognitive decline, and hot flashes. The hot flashes were mild, more like night sweats. Um, but notice that osteoporosis is most often caused by low estradiol, which is caused by having low testosterone. You can get your estradiol brought back up to normal male levels with a patch uh, or other ways of supplementing the estradiol levels. So that's something to discuss. It's not standard of care, but a lot of doctors are doing it because they know low estradiol causes osteoporosis. And uh, not to be a broken record on the thing, when I went off of Orgovix, the last 3 of those side effects disappeared, and the extreme fatigue was lessened. I'm currently using estradiol only, high dose estradiol, and my PSA is 0.014.
Thank you. Yeah, for you guys, this is a not very common, but possibly becoming more common, different way of accomplishing ADT.
Yeah.
It has less of some side effects, more of some other side effects.
Yep. Gynecomastia is one.
Gynecomastia. Anybody
I
else?
yeah,
Oh, Rick.
I'm going to just put in the chat window right now a session that Dr. Wasasu did with us. He's been using estradiol for over 20 years. And he's done a couple of sessions. If you go to our website and you search for estradiol, you'll find it. I'm going to put it in the chat window right now. It's controversial. Works for some, doesn't work for others, has side effects. Depends how it's administered. When it's administered through the patch, there are no cardio side effects. In other forms, there are cardio side effects, as we were talking about earlier on. So, like I say, it's very, very controversial. But this was a group of, I think, 7 or 8 men last year, Al Latimer and a couple of other people, talking with Dr. Wasasug, and here it is. There you go. So you can click on that, and then you'll find a lot more about estradiol in our archives if you look for estradiol. It's not something we recommend, but we accept that it is it's an alternative. There are pros and cons on that patch study. I think it's just reporting out again right now. I forget, but and it also it's a bit like Proton in that there are a lot of people that proselytize for it, and for some people it really does work. Some people it really does work, and they do better, but some people do not. Does anybody else want to say anything about estradiol?
The patch study found it was just as effective as Lupron or equivalent. That was one of the things that was big about the patch study that just came out. You've seen it, haven't you, Rick?
There's no doubt about its ability to lower your PSA. Yep.
Well, it's supposed to be just as good as Lupron if the correct amount of estradiol. And I've got information on the patch study if you want me to send it to you.
Larry just put something in about patch. Okay, gentlemen, it's been nice. It's been a nicely paced group. We didn't feel like we had to rush. And I hope you have a good week, and I'll see you all next week.
Yeah, and just again, don't forget, next meeting is not New Year's Eve. The next is not Christmas Eve, it's New Year's Eve. Okay?
And Doug, I'll be writing to you tomorrow.
Okay. Good night,
Fantastic. Thank you.
Thank
everyone.
you, John.
Bye, everyone.
Bye. Thank you very much for all your help.
You're welcome.
Good night, everyone. Thank you.